Dear colleagues, it's my privilege to report directly from ASH 2022 in New Orleans, and my focus should be myeloma. It's Monday, almost noon now, so most of ASH is gone. I went through the remaining presentations also, so I tried to summarize the entire content and give you an overview and a journey through the both major parts of myeloma ASH this year. What I think is one is the innovation in T-cell redirecting therapies, and the other, of course, the new knowledge and innovation in treatment concepts and treatment programs. So I will start with the innovation in T-cell redirecting therapy, which means bispecific antibodies and CARs. And this ASH has seen the evolvement of a number of bispecific antibodies, which was really the focus this year, I think. So we have three targets that we all know: BCMA, Fc receptor, gamma, and G-coupled protein C5d. And these are all well established, and now we have a number of agents, bispecific antibodies, that target these three established targets. And I think there's about 3 or 4 for BCMA, there's 3 for GRP C5d, and I think 1 or 2 for the Fc receptor. So there's a whole bunch of those, and all over the bench they have in the class of triple refractory or highly advanced myeloma, they all have a response rate that is very similar, 60 to 70% of our response rate. Half of that usually CRs, of which most are MRD negative. So the class is well established, and now we have a number of studies with a few hundred patients in there that allow us to find patterns of the individual targets. I think it's rather the targets than the individual agents. A new group now was a big study on with talquetamab, so the GPRC5D targeted antibody Monumental 1 with about 300 patients, was the first really larger study with this, and I think it's a quite remarkable result that we see there. As I said, overall response rate in this highly pre-treated patient population about 70% as the others, but the toxicity profile is, I think, highly relevant here. We see very little infections, only 15% grade 3-4 infection. That's different from what we have seen with BCMA targeted bites, and also only 5% of patients stopped the treatment due to toxicity. And the main toxicity is really skin and nail toxicity, which is obviously a challenge for us because we don't know it, but given that most patients can continue therapy, I think it's a therapy that is very well suits the patient in this difficult to treat population. So this was about 280 patients for this sub-Q formulation, and there was a subgroup of about 50 patients that looked at patients that were pre-treated with T-cell redirecting agents, so that were pre-treated with CARs or bites and received talquetamab. And also in this population, the overall response rate was roughly 50%, so still a very active agent also after T-cell redirecting therapies, with a very favorable safety profile. And I think the infection issue is important, and it's probably something that can be combined very well. We have seen data on BCMA targeted bites now. Ralantamab is the next commercial agent that has showed a trial now, phase 1/2, with I think 200 patients in that order of magnitude. Same 60-70 overall response rate in the same population, but here you see about 60% grade 3-4 infections, so there seems to be a difference possible. we have seen combinations already, and these agents are now moving a bit more in the more earlier treatment lines. So BCMA targeted BiTE, the teclistamab has now been combined with daratumumab Revlimid in the early relapse setting, so a new setting with very manageable toxicity and a very high overall response rate of about 90%. So these agents can be combined and can be used earlier. So I think this is where the field will be going. In the area of CAR T cells, we didn't really have large new studies, but new important information. One of them is that we now have the technology of obviously to produce CARs much faster, within 5 days, and we have seen that also in the myeloma field, the CARs for the other targets that I just mentioned, they exist, they do work, and they look similar to the CARs against BCMA that we have seen before. Probably higher response rates, but that may be due to the more advanced technology that we now have. We have some more information on Abecma, so on the ID cell, the first approved myeloma CAR in a small cohort that looked after the patients that relapsed very early after initial therapy, within 18 months. And also in that population, we see data that are consistent with earlier data on ID cells. So that's our response rate, about 80%, and a PFS of about a year. This is what is to be expected also in these early relapsing patients. I think that these are the most important pieces from the T-cell redirecting field. And now I try to zoom in on myeloma treatment in general and also on epidemiology. And there is, I think, very important information is the Icelandic data that evolve every year, where the entire population basically was screened for MGUS. And now we know that the prevalence of MGUS is for a population beyond the age of 50 is about 5%. So 5% over 50 have MGUS. And the question now is how many of them have smoldering myeloma, and if they have smoldering myeloma, do we have to treat them, and how do we have to treat them? So to tackle the first question first, we have very good data from Iceland here also that provide an online calculator where you very sophisticated can calculate the likelihood that your given patient has a 10% or more bone marrow plasma cell infiltration in the context of his MGUS, so meaning would probably be a smoldering myeloma, and that you can calculate with your lab work that you have already done for this patient. So this is online, you can try it, and that saves about 2/3 of bone marrow exams that would otherwise be required, at least statistically. Now if we go to the fact of smoldering myeloma, there's still the ongoing question to treat or not to treat, and how to treat. There's two approaches that have been also again presented here. One have a fixed duration treatment with autotransplant, one without autotransplant, and all with the newer agents except for T-cell redirecting therapies. And for both of these trials and experiences, after 3 or 4 years of follow-up, it looks like these approaches achieve molecular emissions as one has expected, but as to now we have no signal that this is in any way much better than we would expect in the similar situation from a patient with myeloma. So to detect a signal here that would be really a cure of a high proportion of these patients, we will have to wait another 10 years until these trials are really informative, and we cannot make this decision right now. In the frontline setting then, in the frontline standard treatment setting then, we have this difficult to treat population, the ultra-high risk myeloma patients, and there was a British trial looking specifically at those and adding to the experience that we have already from the master trial, which is basically having a quadruplet treatment pre and post autologous stem cell transplantation. Now the British study now has added an 18-month consolidation quadruplet therapy after autologous transplant, and the PFS after 3 years is really remarkable. While we know that with the master approach about 50% relapsed within 2 years, now this extended consolidation, intensive consolidation approach by the British yielded 70% relapse-free survival after 3 years. So it looks much better, and it looks as we have found a way how to better tackle also the ultra-high risk myeloma, one of the remaining classes where we don't know how to treat them. In the next question in line would be the maintenance therapy question. How long LEN maintenance in a standard risk patient? How long in a molecular negative patient, MRD negative patient? There's data on 1,200 randomized British patients also that looked at that, and the essence is surprising, I think. The data show that the maintenance therapy should be performed at least for 5 years. Patients still benefit after 5 years, and in particular also the patients that are MRD negative, they benefit from maintenance therapy for at least 3 years. So the message is LEN maintenance very likely for 5 years in the standard cohort, and even in the MRD negative for 3 years. I think this is a surprising result and maybe also a provocative result. We know for the frail patients, that's also very difficult to treat population in the upfront setting, and there was a first phase 3 trial really in frail myeloma patients, so median age of 81 years, looking at the question whether one can omit the dexamethasone, which otherwise we all know is pretty toxic to these elderly people. So it's a randomization of DARA R against the standard RD, and first of all, I think it's shown that this trial is feasible. So it's feasible to do a trial with 81-year-old frail myeloma patients, and secondly, it shows that omitting the dexamethasone does not harm the disease control, but improves the or other words, the daratumumab improves the speed of gaining myeloma control and getting the patients in better shape earlier. So there's an argument for leaving out the dexamethasone in frail patients in the frontline setting, which I think is very important for clinical practice. There's another very important information for clinical practice, that's quality of life in our standard regimens. That's something that hasn't been looked at systematically in large phase 3 trials, and that was done in the Maya setting, in the Maya trial, as well as in the Griffin trial. So our standard frontline settings with or without daratumumab. And the question was, what is the impact of daratumumab on quality of life in these standard frontline therapy settings in the transplant or non-transplant era or situation? And the results are remarkably similar. They show that the addition of daratumumab improves almost all parameters of quality of life, which is not that surprising. But what was surprising is that the control of pain and the speed of control of pain was significantly and very remarkably improved in the daratumumab arms, And the other important and surprising message for me was that in both trials, the time point at which the quality of life of patients again worsens after improving first. So that turn of the curve basically is 30 months later in the daratumumab containing arms. So with our current standard therapy with daratumumab, it takes two and a half years longer until the quality of life of patients again deteriorates statistically. And I think that's something to think about that for us in clinical praxis. There is innovation also in the non-T-cell redirecting therapy setting. I think that's in drug setting, that's probably the last point I'm going to mention. I think two developments are standing out, two new agents, two new drugs, and two new concepts. That's modakafusp, that's a fusion protein of an attenuated interferon alpha that is fused to a CD38 targeting antibody. So it's only a shuttle, this antibody, to target the interferon to the right cells, and that yields about 40% response rate in heavily pretreated patients as a monoagent delivered every 4 weeks once with a very good profile of side effects. I think this is a development to watch that will be a new addition to our armamentarium. And the other one are I think it's called mesigimod. It's at least it's a development away from the IMiDs that was performed on understanding the IMiD mechanism now, and a new compound there that is an oral compound given once daily, has very, very little non-hematological toxicity in a first phase 1/2 trial, and gave about 50% single agent response in heavily pretreated patients, including a 50% single agent response in patients that have been pretreated with BCMA targeting agents. So I think that's also very remarkable new addition to our armamentarium, where we will have to watch what are the combinations, where will we put these things. So in summary, I think there's a lot going on in the T-cell redirecting field. We have a better feeling when to use the bispecific antibodies and how to differentiate between these two. We have a technical innovation in CARs that has not yet reached the patient in the broad field, and we have started to solve the remaining questions in the frontline setting, especially the ultra-high risk patients, I think, where we have now very good data. So with that, I think I have what I can do as a summary of my head, and I'm happy to meet everyone back in Switzerland again in a couple of days. Thank you.